and I would like this opportunity to start the webinar and invite Professor David St-Jules to the Africa Healthcare Network webinar. But before you start, I would just like to give a brief introduction. So Professor St-Jules is an Associate Professor of Nutrition at the University of Nevada in Reno, United States. He has a Bachelor of Science in Nutrition from the University of British Columbia and also a PhD in Nutrition from the University of Hawaii. He has published more than 25 papers in peer-reviewed journals, and his research summary broadly investigates the distribution and determinants of dietary intakes of individuals with adiposity-based chronic diseases, and the role of nutrition in the pathogenesis and the progression of these conditions. He currently studies dietary recommendations for managing potassium and phosphorus homeostasis and preventing protein energy wasting in patients with chronic kidney disease, particularly those on hemodialysis. He will be taking us through the topic changes in renal diet, case-based insights. Prof, you're most welcome, and the floor is yours. Thank you.
Wonderful. Thank you so much. Thank you everyone for being here, and thank you for the invitation to speak today. Okay, I'll go ahead and get started. So as was mentioned, I hope everyone can see this okay. Please let me know if not. My presentation today is going to be changes in the renal diet, a case-based insights. So just before we begin, I'm just going to mention the fact that I chose a fairly broad topic. So I'm not going to be getting into specific details of the studies themselves that underlie this talk. But if there's any questions about that, I'd be happy to discuss it at the end. I know there's going to be some time there. So what I'm going to be doing instead is basically sharing some of the broader trends in the renal diet as I have seen it from the literature, and I don't have any conflicts of interest to report. The reason why I chose this approach is that the field is undergoing a bit of a paradigm shift. And so what will happen is you may, if you're looking into the renal diet, you may see conflicting advice and practices. And I think personally that a historical perspective on this shift is interesting, and I think it can help to navigate the literature and so that you can provide informed patient-centered care. So at the end of this presentation, participants will be able to explain how to identify and prioritize diet-related problems in people with kidney disease, describe the rationale and premise for the recent shifts in the diet therapy for people with kidney disease, and explain nutrition assessment approaches in managing diet-related problems in people with kidney disease. So I'll begin with an introduction of a case. So the case presentation is a 55-year-old male with kidney failure secondary to diabetes and hypertension that progressed to hemodialysis 3 times a week. They are taking medications to manage their sort of dysglycemia, hypertension, dyslipidemia, and they're also taking calcium-based phosphorus binders, and they appear, or at least report to be adherent to those medications and their dialysis treatment. Socially, this person works a desk job, so they're in tech. Their income meets their needs, but they're busy with their family. Their wife works as a teacher. They have 3 kids who are kind of young adult age and 2 grandkids. This person has a sick mother who's already on dialysis. And because of that, they're upset and anxious about their health, and they want to avoid those complications that they see. They've been referred to the dietitian. In my case, I'm a dietitian, so I think of it this way, for low phosphorus diet therapy because they have persistent and worsening hyperphosphatemia. Over the last 6 months, the phosphorus levels have increased from 2.1 millimoles per liter to 2.5 millimoles per liter. Overall, in addition to these things, their condition, they have mild obesity, anemia, metabolic acidosis, and hyperkalemia, but all the different other parameters are within normal limits. So from a diet history perspective, they don't have any prior counseling on their diet, but they are familiar with the diet for hemodialysis because of their mother that I mentioned. And when you ask them about it, they tell you that the diet should promote meat for iron and protein to address malnutrition and anemia, and it should restrict salt and fluid, high potassium and high phosphorus foods like potatoes, they note specifically. In terms of the factors that are affecting their food choices, in your conversations with them, you determine that the main factors are sort of cost, taste, and convenience are the main factors that are influencing their food choices. They do take a multivitamin, and their motivation and goals are that they're looking forward to spending more time with their kids and grandkids as their kids are getting older. And they want to avoid the frailty, fatigue, and complications that he saw in his mother. So perform a bit of a diet history in this patient. You see they wake up in the morning around 6:30 a.m. and they get up and they have some tea. And then in the mid-morning, they have a snack. And that snack is some more tea, usually with a baked good, something like a muffin. At lunchtime, they tend to just get food right around where they work. So it's kind of a convenience meal. And that meal has grain products, some meat, and maybe a little bit of vegetable. And then for dinner time, they have usually a family meal or home-cooked meal. It's going to be, again, some grain, some meat, and some veggie. And then finally in the evenings, they have, a snack typically. So some grain product, maybe some dairy, and tea. And just when you ask them about it, because there wasn't a lot of fruits and dairy in there, they said that they rarely consume fruit and milk. It's not really a common thing for them. So when you look at their actual diet, we can sort of plot it out in terms of the amount of servings of the different foods they have throughout the day. So this is just another way of looking at the same information that was in the prior slide. And so this is their actual intake. And if we were to look at general healthy eating guidelines for adults, you would want it to look something more like this. So although their meals are nicely distributed throughout the day, which is good for somebody with diabetes and hemodialysis, you can see that there's quite a few food groups that are not well represented. So I want to talk first about the traditional diet, the diet that sort of was in place for people on hemodialysis for the last 30 years. So the traditional diet was designed using a specific formula. So the first thing was that they find the offending nutrients. So, and just as an example, patients with hemodialysis develop hyperkalemia. So the idea is that that's probably caused by potassium, too much potassium in your blood, eat less potassium. So they go out and find all the foods that are high in potassium, and then they tell the individuals to restrict them. So avoid high potassium foods. And then they sort of sat on that diet for a very long time. It was never really tested. And that's kind of one of the important things to understand is that they implemented these dietary guidelines, but there was never really any studies testing whether or not it actually worked or was safe. This is an outdated prescription, but I just wanted to put it up there to sort of capture the time period, which was, again, the 90s, early 2000s. So that general patients were told to consume about 25 to 35 calories per kg, per kilogram body weight. They were told to consume a lot of protein, so at least 1.2 to 1.3 grams per kilogram per day of protein to restrict sodium, potassium, and phosphorus. So these are sort of the general ideas. They came up with numbers to sort of correspond to what patients should be eating. And then they translated that into food. And this is a general idea of what the traditional diet would look like. So in terms of the fruits and vegetables, it would restrict high potassium fruits and vegetables. And that's things like oranges, bananas, tomatoes, potatoes. They'll limit whole grains and encourage refined grains because of the higher phosphorus content. Limit dairy products overall because of the potassium and phosphorus. And then finally, I mentioned recommend a lot of protein. So protein with every meal, but limit the nuts, seeds, and legumes, so the plant sources of protein, because of the potassium and phosphorus content. So over time, and this has occurred over the last 20 years, people have identified problems with that old dietary pattern and suggested modifications. So I'm going to take you through a little bit of what that's looked like and why they did that. So there was some concerns with the old traditional dietary pattern, the one that I just showed you. One is that it was notoriously unhealthy, it was very complicated, and it was difficult to follow. For example, the National Kidney Foundation handout that I showed you, that I drew the dietary pattern on a couple slides ago, it has advice to limit and avoid nectarines and oranges, but choose peaches and tangerines. So those foods are very, very similar to each other. It would be very difficult for a patient to memorize a list of food. And that's basically what the diet was for a long time, was these giant lists of foods to limit and avoid and foods to consume. And oftentimes the foods were very similar to one another. There was limited and incomplete direct evidence on the effectiveness. I mentioned they never really tested the diet. It was based on the transitive property. So the idea was, well, whole grains are higher in phosphorus than refined grains, and phosphorus causes hyperphosphatemia. Therefore, we should tell patients with kidney disease to avoid whole grains in order to prevent heart disease. So overall, nobody really liked the diet, and it was really supported by indirect weak evidence. But it was implemented for a very long time. But what ended up happening is research started to identify flaws in the underlying assumptions of the diet, and that undermined the overall diet. And so it slowly got chipped away on over 20 years, the last 20 years. So as an example of how this diet looked like, so again, I mentioned you want to get more protein. So in order to get more protein, they recommended 1.2 to 1.0 to 1.2. That's the current recommended protein intake. And here's an example of specific dietary guidance from the National Kidney Foundation in order to achieve that 1.0 to 1.2 gram protein intake. So eat high protein food at every meal, about 8 to 10 ounces of high protein foods per day. So the assumptions that were built into this traditional diet was that there were no other dietary factors affecting these problems. So they assumed that the only reason patients got hyperkalemia is because they ate too much potassium. They assumed that foods were equivalent. So if you just look in a nutrient composition database, you can find all the high potassium foods, and those are the foods patients should avoid. So they assumed equivalence. And then finally, they assumed relevance. So they assumed that if you avoid whole grains, you'll get less heart disease. They never really tested it, but that was sort of the built-in assumption. So within each of these assumptions, flaws have been identified, and that's really what undermined the diet. So in terms of that causality, just as an example, so dietary potassium intake is not correlated with plasma potassium levels in hemodialysis patients. If it's causing hyperkalemia, you would expect the two to be associated with each other, but they're not. And then also other dietary factors that might cause hyperkalemia have been proposed. I'm just using the example of hyperkalemia. The same is true for protein and phosphorus as well. So dietary fiber and acid load have been thought to be related to hyperkalemia as well. In terms of the idea that everything's equivalent, there's been a few flaws identified, and I'm sort of referring to these as decouplers because what they're doing is you have these foods that are naturally high in a nutrient, but they may not actually be the amount of nutrient that you get when you eat the food. So one problem was that the definition was incorrect for certain things. So I'll give the example of nuts. Nuts are high in phosphorus per serving. They have a lot of phosphorus per serving, but they're also very high in calories because they're high in fat. And so as a result, the amount of phosphorus per calorie is quite low in nuts. And so if we're worried about hyperphosphatemia, we're worried about getting too much phosphorus overall in the day. We don't eat a certain number of servings per day. We eat a certain number of calories per day. So nuts are actually a low phosphorus food. Bioavailability has become a big thing. So this idea that the phosphorus in plants is found in the form of a compound called phytate, and that compound is not well digested. And so as a result, the amount of phosphorus that we get per milligram of phosphorus in plant foods is lower than that from additives. And so that wasn't factored into the traditional diet. Some additional things that have come up is that food processing has dramatically altered the nutrient content of food. So potassium additives, phosphorus additives in food are important sources of those nutrients. And that wasn't factored in the traditional diet. This is an emerging one, but I'll just mention it here, is that certain food processing can actually break down phytate. And so as a result, that phosphorus that was initially poorly digested might actually be able to be absorbed, but we don't have a lot of data on that. That's still emerging. Finally, food preparation. So depending on how you prepare food can cause nutrients to be leached out. So the term is called demineralization, and that refers to cooking foods using wet methods like boiling or poaching. That actually leaches out phosphorus and potassium. So you can have a high phosphorus food or a high potassium food, but if you prepare it in a certain way, it can become a low potassium or low phosphorus food. So finally, I mentioned that there's this assumed relevance. And so some of the flaws that are in there is that diet is a behavior, and diet-related relationships to health are complicated. So at the end of the day, do the potential benefits of whole grains across the stages of people with kidney disease outweigh the potential consequences of hyperphosphatemia? Also, the dose response is usually not known. So if whole grains do in fact raise phosphorus levels, to what extent do they raise phosphorus levels? Because if a person's only having one serving of whole grains per day, is that going to be enough? Avoiding whole grains, does it make sense to tell them to avoid it? Is it going to be enough to actually lower the phosphorus? So these sorts of things were not taken into consideration in the development of the traditional dietary pattern. So just in summary of the traditional dietary pattern, this is roughly what it looks like. So restricting high potassium fruits and vegetables, limiting whole grains, limiting dairy products, and limiting nut seeds and legumes while promoting a lot of animal product proteins like meat. So overall, people don't like the diet in terms of like a health perspective. Patients don't like to try to memorize all these giant lists of foods to limit and avoid. And it wasn't really supported by direct evidence. The evidence was weak and indirect. And then over time, a lot of the assumptions built into this model have been undermined because the researchers come out finding that they're not necessarily correct. So what started out with publications like this, so this one's from Dr. Kalantar-Zadeh talking about, is there anything left to eat for these patients, right? This was a general concern because there's so many restrictions. Is there any healthy foods left for these patients to eat? And then over time, articles started coming out questioning the merit of the old diet, of the traditional pattern. So here's one: whole grains in the Renal diet. Is it time to reevaluate their role? Nutrient non-equivalence. Does restricting high potassium plant foods help to prevent hyperkalemia? Is it time to abandon the nutrient-based renal diet model? And there's still no direct evidence of postprandial hyperkalemia with plant-based foods. So currently the field is still working. So it's cooking. It's trying to figure out the answers to these questions. And the current approach that's being used by a lot of researchers in the field looks a little bit different than the traditional approach. It's simplified for patients, but more complex for practitioners. So the idea is that we identify all of the potential dietary determinants of a disorder. So diet acid load and hyperkalemia, does that play a role? And then evaluate and test them, determine the clinical relevance of this strategy. Develop etiology-based dietary strategies for managing these problems. So if it turns out that dietary acid load lowers the risk of hyperkalemia, then it follows, does promoting base-forming fruits and vegetables actually help with patients with hyperkalemia who have metabolic acidosis? Need to evaluate and test them in controlled settings to determine their clinical relevance and dose response, and then evaluate them in free-living people to see if they're actually behaviorally relevant in free-living people. Because just because something works in a controlled setting doesn't mean it's going to work in your patients. So where is the field? And I wanted to sort of bring this up because this is kind of the rationale for my approach in this presentation. We're everywhere all at once. So if we look at the traditional diet, which this is sort of a basic description of it, and then the sort of simplified diet where we are today, we see that we're in different places. So one of my students recently completed a study where they looked at online resources for hyperphosphatemia. And the recommendations in online resources, if you're to Google, what should I do if I have hyperphosphatemia and kidney disease, you're going to get advice that fits the traditional diet. So most of the information online, patient handouts and things like that, online resources are more in the traditional style. If you look at the dietary guidelines that just came out for nutrition and CKD, and you look at what practitioners are actually doing, they're kind of in between. So some of them are more traditional, some of them are more of the conventional style. But if you look at the literature, right? So this is just my personal opinion, but I read the literature regularly. You look at the Journal of Renal Nutrition, most of the research articles coming out today are focused on plant-based diets, liberalized diets, a lot of the new focus. The traditional diet, you do not see a lot of research in that area anymore, not a big focus in the literature. Where are our patients? Well, they're probably eating more of the traditional diet based on what we see from their diet records. And it just is worth noting that, you can't get hyperkalemia from high potassium fruits and vegetables if your patients aren't eating fruits and vegetables. But fruits and vegetables are important for health. So it's important to consider this in terms of what's best for the patient. So why is it that the online handouts and the guidelines and practitioners are not getting on board with this new approach? Well, if you recall, I said that researchers identified flaws underlying the assumption, which undermined the traditional approach. I did not say that there was an explosion of new research that unequivocally demonstrated that this diet was ineffective and it contributed to poor health outcomes. That research has not been conducted for the most part. There are some preliminary pilot trials, and they tend to support the idea that a more liberalized approach that incorporates some of these foods that have been restricted would be appropriate. But it's still very fluid. There's considerable room for clinical judgment and shifts. So that's something to keep into consideration as you're working with patients around diet. So what does this new diet look like? Well, it just looks like a healthy diet. It just looks like any other general dietary guideline that you'd recommend for somebody with diabetes or high blood pressure. But because the diet is unlikely that most patients are going to follow the perfect diet, it's important to think about other things. So in general, some of the concepts that are being promoted in the literature today is the idea that the diet should be liberalized. Whenever we're thinking about restricting things, we need to critically evaluate whether or not it's actually going to benefit the patient. The dietary should be, it's not a one-size-fits-all approach. You need to look at the etiology of the problem. Do they have hyperkalemia because of metabolic acidosis, or do they have hyperkalemia because of constipation? Right? So thinking about why it is that they have these problems can help direct therapy. We want to focus on therapy that's achievable and relevant. We don't want to just give them everything all at once. It's food oriented. So it's no longer getting into nutrients. It's thinking more about dietary balance and thinking about dietary choices like limiting processed foods. And finally, a term that you'll hear in the literature a lot, if you read this literature, is the term plant dominant, plant-based. It's very much a big focus in the literature today, and it's really targeting the fact that most patients are not eating whole plant foods. So whole grains, fruits and vegetables, nuts, seeds, and legumes, those are not being consumed by patients, and there may be benefits of consuming those foods, even though they've been historically linked to hyperkalemia and hyperphosphatemia, or at least that's been the traditional advice, is to avoid those foods. So with that information in mind, let's go back and revisit the case that I presented earlier. So recall, this patient was referred for a low phosphorus diet because they have this persistent and worsening hyperphosphatemia. Their diet compared to the ideal doesn't really look ideal. There's a lot of potential issues there. In terms of the patient presentation, we have to keep this in mind, right? It's not just the hyperphosphatemia. They've got diabetes, they have hypertension, they're on hemodialysis, they have mild obesity, anemia, metabolic acidosis, and hyperkalemia, but they're mild. They're familiar with the traditional approach. So in terms of where they are mentally, in terms of their understanding, they are motivated, but they're also busy, and cost, taste, and convenience are important factors of determining their food choice. If we look at the traditional diet, or their actual diet compared to the ideal, overall, it seems like they're eating enough grain products, but their grain choices are mostly refined and processed. They seem to be consuming more than enough protein, but the protein choices they're choosing are predominantly processed meat. They're not choosing enough dairy. They're a bit low in dairy, and the dairy that they're choosing is mostly cheese. And finally, they're not consuming adequate fruits and vegetables, particularly fruit. So when we're thinking about designing a diet plan for this patient, we don't want to just give them a handout saying, here's the perfect diet, go do this. We want to help them identify strategies that are going to be most effective. And when we're deciding on strategies, we don't want to choose something that's too small, because although it'll be behaviorally relevant, they'll be able to do it, it might not even be clinically relevant. So we want something to be large enough to produce an effect size. But at the same time, we don't want to give them too much, because then they won't be able to adhere to it. So it's a very fine balancing act. So if we look at the traditional style of diet, what you would do if you were trying to get this patient to follow the old-fashioned diet, they're actually kind of following it, right? They're not eating whole grains. They're not eating high potassium fruits and vegetables. They're not eating dairy products really, and they're not eating nuts, seeds, and legumes. So that old style diet is not necessarily going to be relevant in terms of guiding this patient. So if we look at the more newer style of diet, comparing their diet to the ideal diet, the question would be, is any of these issues that are identified between their actual diet and ideal diet, is there anything in there that might actually help manage hyperphosphatemia without contributing to other diet-related problems? So if we just put them all in a table and just put them all up in front of us to take a look, we can see, okay, well, we could encourage them to eat whole grains, but whole grains are higher in phosphorus. So that's probably not going to lower the phosphorus levels. We could encourage them to eat nuts, seeds, and legumes. Maybe there's something there. There was a preliminary trial that looked at almonds, but it didn't really show a benefit or a risk. So probably neutral in terms of the phosphorus levels, in terms of that advice. Maybe some potential for benefit. Consuming less meat, yeah, that might help. Meat is high in phosphorus, particularly processed meat, because of the additives. We could encourage them to consume dairy, but dairy is a high phosphorus food, so it's probably maybe healthy for them, but it's probably not going to help their hyperphosphatemia. We could encourage them to consume more fruits and vegetables. Well, fruits and vegetables don't really have a lot of phosphorus, so that might help, because if you're eating a low phosphorus food, that means you're probably not eating a food that's higher in phosphorus, so the dilutional effect. So there may be some benefit there, but pretty small. Limiting processed foods. This appears to be probably a good strategy in this patient. Processed foods are high in phosphorus, and there's other benefits of getting processed foods out of the diet. And in terms of dietary strategies that have been shown to lower phosphorus, this is one of the only specific strategies that's actually supported by clinical trials. There's 2 clinical trials in patients with persistent hyperphosphatemia, where they told them to avoid processed foods, specifically phosphate additives in food. And both of those trials showed a benefit. So this is actually one strategy that is evidence-based. Demineralization, so that's that using those wet cooking methods to leach out the phosphorus. We know that it works in terms of removing the phosphorus from foods. In terms of clinical trials, there's not much. There's one trial, it showed some benefit, but it was a very narrow circumstance, and so it's unclear whether that would actually work. It would also require that the patient was preparing all their meals from scratch, which in this patient's case might be a bit of a stretch. So I just made a note here at the bottom that anytime you're talking about changing food, the effect depends on what happens afterwards, right? So I mentioned in terms of if you tell them to eat more fruits and vegetables, whether or not that improves their health depends on what they're cutting out of their diet, right? So that's the aspect of diet that's really tricky in terms of diet therapy, is that you can't just eat more of something else has to leave, and vice versa. If you're restricting something, well, then something else is going to be consumed more, and you have to consider both aspects of the equation. So overall, I would just note care as you're thinking about the diet therapy for patients with kidney failure. The traditional diet was developed using a method that has known flaws. It was not properly tested for safety or efficacy. There are newer translations that are factoring in alternative etiologies, factoring in differences in bioavailability, processing and preparation, among other issues. And that's really driving a shift right now in the practice towards a more liberalized, tailored, food-oriented, and plant-based approach. But it's important to recognize that the evidence is still limited and answers are forthcoming. So a single study could dramatically change the landscape. So it's important to sort of keep up on the literature to see if there are new trials coming out, because those could really be informative. When there's no evidence, a single study makes a big difference. So my final thoughts is that the traditional diet was developed using a reductionist nutrient translation approach, and that mentality of sort of this nutrient approach, this translation approach, persists to this day. But at the end of the day, people eat food. Nutrient food translations are messy and they're prone to error. So we have to be careful when we're working in this area. Trends in diet therapy are simpler and healthier for patients. So these new diets are better for patients. They don't have to have this giant list of all these foods to limit and avoid. But it's more difficult for the practitioner, because you have to think of a lot of different factors when you're trying to provide dietary guidance for your patients. It's not as easy as just giving them a giant list of foods to limit and avoid. So what I will say is my final thought is that evidence-based dietetic practice is found in the premise, not in the conclusions. And what I mean by that is, if you're reading the literature on this, you'll find a lot of really strong opinions and advice, including my own, right? My own opinions. And what I would say is, don't focus on what their conclusions are, what they're telling you to do. Focus on why they're telling you to do it. What is the evidence underlying their particular advice? And oftentimes you'll find that the evidence is not the strongest. We don't have phase 1, phase 2, phase 3, phase 4 clinical trials for every dietary strategy. Oftentimes we're working with incomplete information. And so it's important to understand, well, how good is the evidence? And the way that you'll find that is by reading the rationale that they provide, not their conclusions. So thank you for listening. Here's my information if anyone has any questions or wanted to follow up with me, and I'm happy to take any questions you might have.
Thank you so much, Prof, for that enlightening talk. I must say that it was fairly mindset changing, because I am one of those that practices the traditional type of renal diet, because it seems to kind of stick very well with with us. But it also is, I would say, easy to prescribe. as you correctly said, compared to the balanced one, where it's difficult for us to kind of choose and for the patients to adhere to. So thanks for that presentation and changing the mindset on how we should actually look at renal nutrition. I see Professor Bima has got his hand up, so he can go ahead with the question. Thank you.
Thank you very much, Amal. And thank you very much, Dr. Jules, for that enlightening talk. I really appreciate it. I'm a great fan of diet in kidney disease, and I get all my patients seen by the dietitian who have chronic kidney disease, because I think diet plays a very important role. But my question is, as a pediatrician, remember, I've got to balance not just the phosphorus and the potassium and the sodium, etc., but I've got to factor in the growth of the patient. So that also affects, to some extent, or largely, not to some extent, but to a great extent, in fact, the kind of diet that, I have to give and encourage my patients to have. What's your thought on that? Is there any difference? Because, I know you're talking from an adult perspective.
Yeah, no, this is a great question. I did my PhD work was actually in pediatrics, but I haven't really focused on pediatrics in kidney disease. And I understand exactly what you're referring to. And I think it actually makes the new approach that factors in nutrition a lot more relevant. So when you're thinking about growth and development in a child, it's super important that we get all of the essential nutrients to support growth and development. Right? And restricting a bunch of foods and telling them not to eat a bunch of foods is not, particularly when we're telling them, oh, you can't have dairy, you can't have it. That's not really conducive to health. And I think there's also a potential in children to be extra worried about the protein question. And so to overemphasize protein, and what I would say is a word of caution. Getting enough protein is essential for child development and growth, absolutely. And those protein foods are rich sources of iron, and iron deficiency is a major problem. But overdoing it, the physiology is not dramatically different. So to my understanding, and what I mean by that is if you overeat protein, you're going to contribute to metabolic acidosis. If you overeat on animal-based protein, you're going to contribute to uremic toxins. If you overeat on protein, you're probably not getting a lot of fiber. And there's a lot of things to keep into consideration when getting imbalance, right? So if you're recommending a diet that doesn't follow the general healthy guidelines, that imbalance has the potential, particularly in a growing child, to compromise their health and well-being. So I would say it's actually more important to really emphasize healthy eating, because at the end of the day, although they have kidney disease, they're still a growing person. And a growing person needs all of their essential nutrients. That's first and foremost what nutrition should be about. We can fix problems with medications, right? But it's hard to fix all the problems with just a multivitamin. There's a lot of things in food that are difficult to sort of capture if we're not doing it with food. As an example, omega-3 fatty acids, right? So that's something that you could supplement that, but that's not going to be in a multivitamin, right? Multivitamins don't tend to have those nutrients. And same thing with the bioactive compounds in food that we don't really understand yet. So the flavonoids, the carotenoids, what role do they play in growth and development? I don't think we have a firm answer on that. But given that there is no firm answer, and given that this restrictive diet hasn't really been shown to be beneficial, I would think that if it was myself, I'd want to be closely monitoring and as much as possible trying to focus on an approach that would give them the best nutrition, without obviously exacerbating their health problems. And I'll just make one more comment, because you mentioned it. That idea of referring to a dietitian, I think, is a great idea. It's getting very, very complicated within this field, and we need specialists. It's very difficult to keep. This is all I do is read the literature all day, and it's difficult to keep up with all of the things that are going on. And it's gotten very, very complicated with our current food system getting so complicated. And so I would say having, delegating to somebody who focuses in this area is a very good use of your time and very good use of resources if you have those available to you. So I would strongly encourage that practice.
Well, thank you very much. If you just allow me, I just want to do a follow-up on that.
Yeah.
One of the things that I noticed when the dietitians prescribe a diet is they have to factor in cultural differences and they have to factor in cost. Because many of the patients, when I go back in the morning, they'll say, the dietitian came to see me, but doctor, these are the food they prescribe, but if I go to Woolworths to buy this food, it is so expensive, I can't afford it. You understand, man? So I think we have to be cognizant of those two factors, and there are, of course, cultural differences. I mean, I live in South Africa, so, we see people from different cultural backgrounds. And indigenous Black patients have a slightly different diet compared to, say, Indian patients who have different diet from Caucasian patients. And, that needs to be factored in. It's not a one size fits all. So I think those nuances need to be taken into account before, we can prescribe an appropriate diet for the patient, well, so-called appropriate diet.
Yes, and I am very much in one of those dietitians who's in favor of the idea that you do have to meet the patient where they are. It's not about giving them the ideal diet. That's not a realistic target for most patients. You really did. That's why I sort of put in that slide where I talked about finding the right level of strategy.
Sure.
And the right level of strategy may be canned food, right? Canned food can be cheaper. It tends to be higher in sodium, which is a concern, but there are things that you can do to mitigate that. So I think it is kind of that tailored approach. And that's why I'm not a fan of this, give a person one thing and just say everybody gets the same diet and here's the ideal diet and go try to figure this out yourself. Because cost, taste, and convenience are the number one determinants of food choice. And if you ignore that, and you're not really helping anybody, I don't think. I think you have to really think about what is driving your food choices and how can we work with you to find that low-hanging fruit that will give you the best bang with the minimum effort, something you can really sustain. Because if you don't sustain it, it's like a New Year's resolution. People go out and they try to follow these perfect diets, and then the trope or the thing is that they can't stick with it, right? And if you can't stick with it, there's no real benefit. Diet works over long periods of time mostly. It's not really an acute treatment usually. So I think that's a really good point.
Thank you. I really appreciate that.
Thank you, Prof. Bima, for those questions. Thank you, Prof. Jules, for your answers. We've got a couple of questions from the attendees. The first question is, should our patients eat deep fried food, including deep fried snacks?
So I would say that it could be, I would say generally no. So that's the short answer is generally no. And then again, obviously the answer is always, it depends. That may not be the focus of my dietary strategy, depending on what else is going on in their diet. There may be more priority issues for me to focus on, but deep fried food, no. And there's a few reasons for that. Dr. Urabari has done some really interesting research looking at the effects of those sort of dry, high temperature cooking methods on the formation of advanced glycation end products in food and the fact that those get absorbed into the body. So that could be, for example, one issue that could be playing a role, because those advanced glycation end products are associated with things like inflammation. And obviously inflammation can contribute to all sorts of problems, malnutrition and many other issues. So I would say it may not be the priority issue, but it would be something that I'd be thinking about getting out of the diet if I could, if it became down to it. Yeah.
Thank you. But we've got another question from one of our dietitians that works with us at AHM, and he has got, I think, two parts to his question. The first part is, what are the potential interactions between certain medications and the nutritional management of hyperphosphatemia, and how can these interactions be mitigated? And his second question is, how do different cooking methods and food preparation techniques affect the phosphate content of foods? And are there any recommendations for minimizing phosphate levels during cooking?
Excellent. Yeah, these are great questions. So to your first question about drug-nutrient interactions, I think the two things that come to my mind is obviously the binders and the new medications that are available for reducing the absorption of phosphorus. Obviously, those have an effect on phosphorus bioavailability, which can be very good, but they do have side effects, and the pill burden can be an issue. So I think those are certain issues. Like the side effects could affect nutrition in indirect ways, right? If you're feeling nauseous or you're having sort of bowel problems because of your binders, that could be a real issue in terms of getting adequate nutrition. So sort of an indirect way. The other thing is that certain medications contain phosphate additives in them. And so that's another one that I'm not an expert in. That would be a good question for a pharmacist. But some people I know have been looking at medications as a source of phosphorus and looking at whether or not we can reduce phosphorus load by getting patients off medications that have phosphorus in them. So those are two things that come to my mind immediately there. Now, for your second question about cooking methods, so there's a few studies on this. I would suggest checking out the study by Dr. Kupisti et al. And what they did is they cooked different meat products using boiling. And so any wet cooking method. So if there's a water medium, that's what I mean by wet cooking method. It's called demineralization. You cook the food using that method. Not every food works this way, but some foods that are high in phosphorus work really well, right? So certain grain products that are cooked grains aren't a super high source of phosphorus, so I wouldn't focus there. But legumes certainly can be cooked using wet methods, and then meat in particular can be cooked using wet methods. Now, the key to this is that the phosphorus in the food, about half of it, depending on how long you cook it for, about half of the phosphorus will leave and it will go into the water. Now, if you throw out that water, then you've removed it. But if you don't throw out that water, then you're probably still going to get it, right? So it doesn't really count if you don't throw out the water. Now, the reason why I'm recommending the article by Dr. Kupisti et al. Is they didn't just measure phosphorus, they measured protein, and they found that the protein was retained almost completely. So that's great for protein, but something to keep in mind if you're using wet cooking methods or you're encouraging it is that it's not just the phosphorus that leaks out. Any water-soluble nutrient, including the beneficial ones, will leach out into water. So when you throw out that water, that means that a lot of the water-soluble nutrients that are beneficial will also be lost. So if your priority is getting their phosphorus under control, that's a great approach. And in general, a lot of the water-soluble nutrients, we do consume enough of them. So it may not be an issue in your patient, but it is something to keep in the back of your mind as you're going through this. You're not just losing phosphorus, you are losing other nutrients, but at least we know that protein is retained. So and a lot of the nutrients you lose, like potassium and sodium, are ones that people are trying to limit anyways. So you can actually kind of do a few things at once, but it does require that the patient is cooking their own meals, right? So if they're not preparing meals at home from scratch, it's not really going to be an effective strategy. There was one trial. I'll just mention that one more before I go on this topic, but I can't pronounce the name. It's in my systematic review on phosphorus. I won't attempt to try to produce the name. But in that study, they actually provided the meals during dialysis, 2 meals per dialysis session, and they demineralized the meals, and they managed to significantly reduce phosphorus binder usage without actually any meaningful difference in phosphorus levels. So I think that's the one study that I know of that suggests that there may be some clinical relevance. But again, they have 6 meals a week that they're controlling. And we don't usually have that kind of control over our patients, at least.
Correct.
We don't provide meals during dialysis. So it's an important consideration.
Yeah. No, thanks, Prof, for that answer, fairly detailed. And I must say that there are certain centers that do provide food during dialysis, but obviously we're not sure about the way they cook, etc., and all of these things. So we're not sure on the quality of the cooking and what kind of cooking methods that they use. But point taken that you need to kind of do it on your own, on yourself, and you have to do it the right way. Otherwise, you're not able to control the phosphorus. Is it safe to say that avoiding any kind of processed food is something that a renal patient should do in order to prevent, say, hypophosphatemia or hypokalemia or increasing sodium levels?
I think for most patients, it's the lowest hanging fruit. It's not easy. So that's the challenge. But I would say, yes, that's probably the best evidence, at least in phosphorus, is in avoiding the processed foods. And in general, getting away from processed foods is probably going to be the easiest, best way to help your patients. But again, it's hard to just tell patients to just stop eating processed food. So I think it's kind of an individualized thing, but yes, that's always on the top of my list.
Yeah. Thank you, Prof. Does anybody else from the panel have any questions? I don't see any further questions okay, one moment. Stifa is asking a question. Is it okay we make dietary plan for dialysis patient individualized? Can we take it as a prescription?
Yes. So individualization is something that I think is paramount. I think that's probably, I would say, more important than the processed foods, because that's a one-size-fits-all thing, is individualization. In terms of prescription, that makes me feel like you're maybe thinking in terms of nutrients. I would think more in terms of food prescriptions. So telling patients, let's talk about some strategies, like I see that you're always eating out for lunch. Is there any way you could prepare large meals on Sunday night and pack a lunch? Like that would be more, I'd be thinking more strategically about behaviors than thinking about prescriptions, because we want to get behaviors to change.
Thank you, Prof. I've got another question. Does this imply that each meal for a patient undergoing dialysis is personalized? Does this imply that each meal for a patient undergoing dialysis is personalized?
Not necessarily, right? If we're talking about in-meal dialysis provided meals, I think it's impractical to get at that level of granularity. I think practically speaking, you just wouldn't do that. You would just give a healthy meal because the patient's not really going to have the choice as much, right? So you get to provide them a good balanced meal. But it is worth noting that broadly speaking, one strategy that would be beneficial in one patient could be harmful in another. I could tell a patient to avoid meat because I'm worried about their metabolic acidosis. Another patient could get iron deficient. So individualization is necessary. Yeah.
Thanks, Prof. Another question we have from a participant is, why do nutrition status of chronic kidney disease patients reduce gradually, even when they are under supervision from the best dietitian and nephrologist? And can we say kidney transplant is the only option to reverse the patient back to its pre-renal condition, so pre-end-stage kidney disease condition?
I would agree. I would say that, it's the nature of diet and disease. And it doesn't really matter. It's not specific to kidney disease. Any disease, as it gets really advanced, malnutrition is going to become a downstream consequence of the disease, because the disease makes patients anorexic. It makes them, it promotes what we would call, it's basically anabolic resistance, right? And you're biologically not able to functionally use the protein in your diet. And there is some good research showing that, for example, correcting metabolic acidosis actually can help patients use their protein better. So without actually giving them more protein, it actually lowers their protein requirements. So I think we need to think differently about diet. But yes, I would agree that it is an eventuality of most diseases. Malnutrition is a reality, and we just need to do our best to sort of manage and mitigate it. But we're not going to use diet to reverse disease, not at that stage, in my opinion.
Thank you, Prof. I don't see any further questions in the chat and the Q&A. I'm not sure if we have got a comment from Bernard. Says, thank you, Dr. David, for this wonderful presentation. You mentioned that the trends in diet therapy is more complicated for clinicians. I'd like to hear from you how interdisciplinary approach among clinicians could be.
I think in terms of, you can't treat a problem unless you know how to assess it, right? So unless you have foundational training in how to assess diet, then it's going to be really, really hard to come up with the best strategy to help a person fix their diet. So that's why I think dietitians should be playing a leadership role in this area. But having said that, a multidisciplinary approach is fundamental, right? Working with the pharmacist, working with the physician to make sure, is there another way that, I'd love to treat their metabolic acidosis with diet, but it's a lot easier to give them sodium bicarb, right? And that's probably going to work better for most patients than getting them to eat more fruits and vegetables. So I would definitely not think that just because a problem is caused by diet, it doesn't mean that diet therapy is the best strategy for fixing that problem. We have to be realistic about what diet can be achieved in which patients. And so I think a multidisciplinary approach, making sure that we're working together and saying, hey, I'm probably not going to be able to get there with fruits and vegetables. Can we talk about sodium bicarb? Or I think it is a team effort, and medications in particular can play a big role in terms of managing problems that are caused by diet, which is unfortunate, but again, realistic in terms of, we have to approach this in terms of how do we help this patient. So I would say multidisciplinary is necessary.
We've got another question. It says, is it advisable for chronic kidney disease patients to eat anything they are restricted to eat intradialysis? So should they be able to eat anything that they are restricted to eat, but they should eat it intradialysis, example for potatoes or something like that?
Yes, I've heard of this. I think I understand the question. This is like the idea
Yeah.
of like the cheat meal right before you start dialysis because
Yes.
you're going to get
Right.
dialysis and it'll remove that.
Yes.
I'm not a big fan of
Yeah.
that. No.
Yeah.
Because the thing is that, you know, often these cheat meals, right, going out and doing something right before dialysis that isn't great for you, you're about to undergo a very hemodynamic instability period. And
Correct.
just going out and plowing yourself with a whole bunch of potassium is a terrible idea. So I would
Yeah.
say, no, it's about long-term planning and strategies. And then if the question was about intradialytic meals, I think that's another interesting debate. I'm personally in favor of them. But obviously, if a person's not eating healthy choices during dialysis, it could be net not good, right? Because often you might be tempted to choose convenience foods because you're on the go and you're going to go get dialysis.
Correct.
So that might
Yeah.
not necessarily be good. So it really is patient specific. And also, if you have a patient who's keeps bottoming out in their blood pressure when they're eating, that might not be net beneficial for them to eat, even if they are experiencing malnutrition. You might need to come up with an alternative strategy to get the malnutrition treated, because obviously hemodynamic instability during dialysis, low blood pressures could be very dangerous. So I'm not a one size fits all in any scenario kind of thinking.
Yeah. Thanks, Prof. Just maybe maybe my personal experience, I had a patient that was a very rigid patient. I mean, he knew his dialysis in and out, so he would go in and decide what prescription he's going to give the nurses. And, you know, says, okay, today I'm going to do 2 hours, but just increase the blood flow rate, etc. This kind of patient, you know, the patient that would direct the nurses what to do. So he was a patient that would come in with a bag of crisps and a bottle of Coke and sit there while he's going dialysis, he's munching on it and he's drinking, you know, the Coke. And despite adequate, you know, counseling on, you know, the inappropriateness of the diet, etc., and all of these things, he didn't listen and ended up a year later down with very bad mineral bone disease because of, I feel that he just overloaded himself with bad stuff, including the phosphate. So he then eventually kind of moved out. He went overseas. I'm not sure where, but I think these things are some things that we need to kind of be wary about. It doesn't mean that if you're undergoing dialysis, it means that, you know, the food goes into your stomach and then goes into the blood and it's filtered out. It has to be absorbed. And this can take a while, especially with the changes that you get in the gut while you're going on dialysis. So it is something that we need to make sure that we tell our patients. Dr. Lloyd has a comment, and he says, thank you for your impactful and outstanding presentation, full of very important new thoughts and the concepts. We will make the video available in the next few days for those who want to revisit it or those who missed the session. And I think we're going to take the last question from one of our medical doctors working with AHN. He asks, what's your comment on prescribing nutritional supplements to dialysis patients? So I would think the powdered nutritional supplements is what he's asking.
Yeah, absolutely. So I consider that to be supportive care, which can be an effective strategy for managing problems in certain subsets of patients. But my priority is always, if possible, etiology-based care. And what I mean by that is, let's say a person's malnourished and you want to give them an oral nutrition supplement. Well, they're not malnourished for no reason, right? And so you're not fixing the underlying problem by giving them an oral nutrition supplement. Something's causing them to be malnourished, and that thing might be modifiable. So I always want to look for that thing that might be causing them not to eat well. And that would be my priority. But that's not always going to be achievable in every single patient. And realistically, sometimes just getting the person healthy is the most important thing. And oral nutrition supplements or powder nutrition supplements, those sorts of things can be very effective. But we need to recognize that you're basically kicking the can down the road. You're not fixing the problem. And so that strategy is going to be effective, but it's eventually going to reduce efficacy over time realistically. And it probably is not going to just all of a sudden fix the reason for the malnutrition. And so I think that's kind of what I think about it. I think it is part of our toolkit and we should absolutely use it, but it would never be my first and foremost strategy unless I thought the situation was dire and desperate and urgent. And then I would say, okay, yeah, let's do this. But it would not be my first line of therapy.
Thank you very much, Prof. I must say that this was a very insightful and enlightening talk, and I personally have learned quite a bit. And thank you very much for taking all our questions from all our participants. And we'd like to thank you once again for coming through to our chin for your talk, and would like to have you again sometime in the future for another talk on a similar topic. I'm not sure if Dr. Lloyd has got anything else to add. Yeah, I think maybe he's got a connection problem. But yeah, thank you very much again, Prof. It was a pleasure having you.
Yes, thank you very much. And thank you for having me here. And it's been my pleasure as well. I really enjoy talking about this stuff. And on that note, this is my information. If you want papers, if you have questions, you can always reach out to me. I'm always happy to sort of work with the community and try to share what I've learned through my, again, literature perspective. I'm a researcher, not a clinician. So I'm coming at this from a very specific angle, but I think we can work together and that is going to be the key to helping patients. So please do reach out to me. Don't hesitate if you have any questions or if you want a paper on a topic, I'd be more than happy to try to find a couple for you. So please, thank you again and have a good evening.
Thank you so much,
All right.
Prof.
Yeah.
It's so much appreciated. Have a nice day further. Thanks.
Thank you.
Bye.
Dr.